And then, yes, make sure that you are gathering all of your photos, and that once you get who's ever gonna be in charge of that is getting all of your photos for the slideshow. Okay? Okay, cool. All right, let's dive back into lecture. Now we're gonna start with going over the health assessment of kids. Okay? So, your health assessment, head to toe. This is what we're going to go over, right? Does it look different in adults than it does in kids? Yeah. To an extent, right? Some things we're looking at that are like peds specific, but otherwise you're still kind of following the same routine, right? You're going head to toe, because we call it a head to toe for a reason, right? You start at the head, and by the time you get to the toe, you should be done, right? However, there is some developmental aspects that you have to take into account when doing your head to toe assessment with a child, right? So part of your assessment is gathering what data? Vital signs. How are those going to adjust your approach to your assessment in a younger child versus an older child? Okay, so knowing your parameters, right? But where are you going to incorporate gathering that data in your assessment? Excuse me. Because do we normally do it first?
No. Get vitals first.
Does it matter in your adult patient? Does it matter if you do your head to toe assessment or gather vitals? No. Does it matter in your younger kids?
Yes.
Yes, absolutely. Why do we want to get our vitals first?
You might freak them out.
Might freak them out. They might get more agitated. Are your readings going to change if they're screaming and crying and kicking versus if you got those first and they were nice and calm? Yeah, they will change, right? So for our younger kids, we definitely want to make sure that we're getting those vital signs first while they're nice and calm, right? What is a method that we can use to help make sure that those kids remain calm while we're gathering those things?
Maybe use it on us first, or
Okay.
like mimic using it on us.
Absolutely, absolutely. Incorporate that medical play, right? Okay, what else?
I said, or on mom and dad.
Or have them sit with mom and dad, right? Where they're nice and comfortable, where they feel nice and secure, right?
Could we have the parent maybe like put the blood cuff on them, or put like the thermometer, or no? Or that's like.
You could try, yeah. If you show them how to do it, yeah, they might be okay with that. We tend to flex a lot when gathering that data because the kids might not like us and they just might freak out, right? Sometimes it doesn't matter how we approach them. We can approach them in the nicest way possible and they're still gonna scream the second they see you, right? So you just kind of have to flex, right? Do what you can to get those things. But generally, for our younger kids, we want the vitals first before we go into our head to toe. For our older kiddos, it doesn't matter, right? Like getting the vitals isn't gonna upset them, so it doesn't matter whether you do your head to toe first or your vitals first, okay? So, making sure that you're gathering a good health history, right? So what are your components of your health history, right?
Past medical conditions.
Past medical conditions,
Past
past procedures,
allergies.
allergies, their demographics. Who are they, right? We want to know who they are as a person, right? What is their age? What's their gender? What's their socioeconomic status, right? Why do we want that information?
It'll determine our care and what resources they need.
Absolutely. It's going to incorporate into the individualized care plan, right? And guide our care delivery. So we want to know these things so that we know what resources we need to start finding for them, right? Okay. So we want to know about their chief complaint, their history of present illness, right? When did it start? What makes it better? What makes it worse, right? What brought you in today? How long has this been going on? What is their past health history? What's their family history? Why do we want to know that? Okay, could there be a genetic component as to why they're there, right? Is it a congenital thing that was passed on, right? So we want to know, is there a family history of this, or is this completely new? Is it not related, right? Or are they're just sick because they're sick, right? Their developmental history, their functional history, so their milestones, growth patterns. Why is that important?
To know like how to do your care, like teach them or
Yeah, again, where are they at? Where do we have to meet them, right? Where are they at developmentally, and how do we, again, adjust our approach to them to get the best outcomes?
If they are baby, it's important to ask about their pregnancy.
Absolutely. Yeah.
We have your-
Actually, in kids, we ask about pregnancy history no matter what. No matter what. Because anything up until the age of 18, if in any way it can be related back to pregnancy or birth, or like birth trauma, anything like that, it is held accountable in that time frame. Yeah. So labor and delivery nurses, like, they're on the hook for a long time. And then family composition, resources, home environment. So knowing about their family structure, their resources, their living conditions, why is that important?
To give the appropriate resources.
Okay, again, appropriate resources,
Appropriate education.
appropriate education to the appropriate person or persons, right? Who's the primary caregiver of this person, right? They might live at home with mom and dad, but maybe they're only with mom and dad at night because mom and dad work all day. So who's taking care of them during the day? Do they do they have like a multi-generational household? Are grandparents there? Do they live with aunt and uncle? Are they adopted? Right? Do we even know their family history? Right?
Would it also be to identify any barriers to compliance, like maybe?
Absolutely. Absolutely. All of this information we want to know because it's going to help us provide the most individualized care plan and delivery of care to that kid, right? So that we're not missing anything. What about their living conditions? Why is that important?
They want to test the kids for bed pregnancy.
Yeah, right. Maybe they don't live in a very clean living environment, right? So could their living condition contribute to the condition that they're presenting with, right? Okay, so we want to know, do they live in a household that's like full of mold? Do they live in a household that's full of pets? Do they live like in a hoarding condition, right? We want to know those sorts of things, okay? Because that very well could play into why they're sick and why they're there.
How do you find out that? The parents are not gonna
You could ask them. Sometimes they're very forthcoming. Sometimes you have to like kind of build a little bit more of a rapport with them for them to be forthcoming with that information. If the child comes in and they're dirty and very unclean and stuff like that, we can get child services involved, and they can go do like a home visit and they can go check. We actually not too long ago was running into a condition with one of our oncology patients who was her caregiver was technically her grandmother by blood, but grandmother insisted on being called mom and had some neurologic issues of her own as far as like memory issues and health issues in general. She was a right or left leg amputee. She was wheelchair bound. She's a larger woman. She had open sores. She had an indwelling catheter. Like, she couldn't take care of herself, let alone this oncology patient. And so we, like, the number of times that we got the healthcare team together with like the ethics board and everything like that to try to get her placed with another more suitable caregiver was ridiculous. How many times did we meet, Michelle?
I can't even.
Like multiple times. We knew that this was not a great condition. Like every time the caregiver came in, she smelled, she couldn't move herself from the wheelchair to the couch. Like she also had a colostomy, as well as an indwelling catheter. But she is not our patient, and it is out of your scope of practice to take care of a family member who has those medical issues while you have someone who is your patient there. And so she, at first, was like, can you empty my Foley? Can you take care of my colostomy? And some of our nurses were doing that, and then others caught on and were like, no, you can't do that. And so then when we started refusing to do that for her, then it became an issue, and child services was involved, and like it was not a very clean situation. The other kids that she had in her care also had intellectual disabilities, and were essentially her primary caregiver, and so it was just not a great situation. And it got to the point that they fired us as their healthcare team because we were trying to push so hard to get her removed, and so they went to PCH. And beyond that, we don't.
CPS is already involved, right?
Huh?
That point, CPS is already involved.
Oh yeah, they
have been
were
involved.
involved from the
been
moment we
involved.
found out like that she was the primary caregiver. So it's not, they might not necessarily be forthcoming in providing the information to you, but in what you're gathering from the situation, and as time goes along, you're gonna kind of pull those pieces, and things are just gonna be like, yeah, this isn't right? Like, you can't have someone who can't take care of themselves taking care of an oncology kid who needs very specific meds at specific times, and monitoring and close observation.
Immunocompromised, living in that kind of environment.
Exactly, yeah. And the number of times she came back in like sick, it was just like, I mean, the caregiver had, like I said, she had open wounds, and like she would sit there and like fondle her, like caressing me back. It was not a great situation. So again, they might not be forthcoming, but you're gonna see some of those things, and then you're gonna like escalate that up and be like, hey, something just doesn't feel right about this situation. Like, can we investigate more? Can we have like a home visit or something like that? Yeah. Okay. But all of those are important pieces, right? Because that's gonna give you the biggest picture of who your child is and what you need to do for them, right? So when we get into our well child visit simulations next week, okay, these are all of the things that you're going to be asking, right? There's more, but there's more to that. But this is a lot of like getting the background of your child, right? So we want to know these things before we really move forward, right? We want to gather that information, okay? We want to know their prenatal and perinatal history, right? Why is that important? If there was trauma, if there was infections, right? Like, what happened during pregnancy or right during delivery? Did something happen? Was there an injury that occurred? Was mom exposed to a toxin? Was she sick, right? Could that have caused the reason why this child might have developmental delays or is presenting with the condition that they're presenting, right? Past illnesses, we kind of already talked about that, right? Have they been sick before? Is this a chronically ill child? Are they frequently sick? Or is this like the first time, right? Their developmental concerns. We're looking at, are they hitting their milestones, right? So again, on that, when they come in for a well child visit, one of the things that they want parents to do is fill out this form that says, my child is doing this or is not doing this. What concerns do I have? That's the first indication that the child is doing what they should be doing, right? Or not doing. So my son was born 5 weeks premature. So in premature infants or children, do you adjust for their gestational age?
Yes.
Absolutely, right? So really, if your child comes in and they're chronologically 2 months old, and so for my son was born 5 weeks premature, at what age should you be assessing those developmental milestones?
Wouldn't be like one behind.
Essentially one behind, right? 5 weeks prior to where they are, right? So he was rolling over before he should have been, from front to back, and because they really don't do that until like 3 to 4 months ish, but because he was premature, it was weird that he was doing that already, right? So sometimes milestones that they're hitting they're not necessarily a good thing. It can be an indication of a neurologic issue, right? Luckily, he doesn't have that other than ADHD. But our pediatrician almost dropped him on the floor because she didn't believe me that he was rolling over at our 2-month appointment already. Because he was premature, and she's like, there's no way that he's doing that. And some parents like to embellish what their children are doing because they see them do it one time or they were really close to doing it one time. They're like, yeah, my child can do this, yes, right? And they're like, oh yeah, my kid's doing that. Well, really they're not. And so then we look at them and we're like, are you really? And I'm like, at that time, like I was a pediatric nurse. I was actually working in the NICU at the time. So I was telling her this as we were going over milestones, and I was like, yeah, he can roll from front to back already. And she's like, no way. And so she does her whole assessment, and she brings it up again, and I'm like, I'm telling you, he rolls over already. And she's like, all right, well, let's see. And so she puts him on the exam table, and she turns away, and he instantly rolls off.
As she was trying to see.
She turned slightly to look at me, and he rolls off, and she caught him right before he hit the floor. She literally went like this. And left. And didn't say anything. Didn't say, I'm sorry, I almost dropped your child. Sorry, I didn't believe you. She just walked out. We did. We did. And then I had issues with that one. But the MA came in to do his immunization, and I was like, she almost dropped him and just walked out and didn't say anything. And she's like, she didn't know what to say. She walked out and was like, I almost dropped a kid because I didn't believe what the parents were saying. And so she didn't know what to say. So she just walked out because she was embarrassed. And I was like, okay, I understand, but a simple apology would have been nice, right? So it's really important, right, that we're not only assessing those, but we're taking into account what the parents are saying, right? Because yes, they do like to embellish sometimes, but sometimes, yeah, they know their kid best. They're with their kid majority of the day, right? If not all day long, okay? Accidents, injuries, hospitalizations. Why are those important?
So they can see records of maybe something that happened and what they could do, or like previous incidents and how they handled it, or like.
Yeah, because was it documented?
Yeah.
Because if it wasn't documented, it didn't happen, right? So if there's no record that kid broke his femur, what are we going to think about it when we do a scan because maybe he broke something else and it's caught on the x-ray? Could be abuse, right? So we want to know, are there documented accidents, injuries, hospitalizations, right? What's their diet like, their allergies, immunizations? Why are those important? Are they getting the right nutrition, right? So when they're younger, do they usually eat pretty well, pretty balanced? Sometimes. We have more of an issue with that with our older kids who are on the go, right, and would prefer to just drive through a drive-through. But our younger kids, for the most part, are fairly healthy, right? Are eating healthy. Especially when they're like first starting on like baby foods and stuff like that, right? They should have a good balanced diet with all of the stuff that they're getting, right? As they grow and transition, they might get a little bit more picky in what they're eating and only want chicken nuggets, and they have to be in the shape of dinos or it's not okay, because heaven forbid you get the balls of chicken nuggets and not the dino nuggets. Yes. Yes, like the popcorn chicken, right?
The way you said that, just like, ugh.
Yes, the little the nuggets, right? But they're the balls.
Entire case of blueberries, and the next week they don't like blueberries anymore.
Yeah. Oh my gosh, because it said chicken nuggets on the bag, but they were not dino shaped, and I was like, it's the same meat, but they don't look like dinos. It's not the same. It's not the same. Good thing is he's fairly good with what he eats. So the earlier they start with proper nutrition and diet and keep up with that, the less picky they are going to be. So the parents or caregivers who incorporate a variety of different fruits and veggies and meats and stuff like that and keep introducing those things as they grow and develop, research shows that they are less picky when they get older, right? So they tend to eat much better when they've had that variety of stuff.
So you're telling me they'll grow it? Slowly.
Sometimes.
It's gonna take some time.
Yeah.
Good.
I'm not friend, okay?
Good luck.
Like Lucas had a nanny when we first had him for the first 9 months, and when he first transitioned into baby food, like I would go shopping for like fruits and veggies, and our nanny would cook them, package them, process them, all of that stuff. All sorts of combinations of things, spices, once like we got past the one thing a week. And that really has led to him being less picky and choosing healthier options versus unhealthy
I
options.
feel like they go through a stage though, because like in the infants and when you're first introducing food, like that first year, maybe even year and a half, they're like great, they're loving it, everything,
Yes.
they eat everything, you expose them to all these things, and then they get into this
Yes,
2-year-old.
sometimes they can. And Lucas definitely did that for sure. We went through a period where it was like chicken nuggets all the time, right? But the side of that was he would much rather choose a healthier like side option than an unhealthy side option. So he will sit and eat grapes and like cherry tomatoes and cucumbers all day long. Like he will over like a bag of chips. He definitely will choose like those healthier things versus like the unhealthy ones, which is super awesome, right? So again, that proper education, the proper diet, we want to know how are they eating and how can we make sure that they're getting their balanced diet, right? And again, those medication supplements, so what are they taking, what are they on, what are they supplementing things with, kind of goes into like the menstrual history, so that's really important for our adolescent girls, right? We want to know what their menstrual history is like, because it could lead into medications and supplements, right? Especially what? Okay, birth control, or like iron supplements. So maybe they're a heavy bleeder and they've got like iron deficiency anemia, right? So that's in the pediatric population. When we're looking at iron deficiency anemia, we're looking at like our adolescent girls, right? Or our adolescent individuals who have menstrual periods. I want to be politically correct. Yeah. And then that kind of goes back to the diet, right? Because if they've got iron deficiency anemia, they're also taking a supplement. What does their diet look like? Are they getting enough iron in their diet, or do we need to increase that as well, right? Do we want to just do a supplement, or is their diet alone something that we can change? Cool. The growth charts. Have you all seen the growth charts?
Yes.
Okay. What do they tell us?
How they're growing.
Yeah, how they're growing. Absolutely. All right. So we're looking specifically at their height and weight, and we're looking at, are they growing appropriately based on everyone else in their gender, in their age range, right? So, so the bottom curve is their weight, and the top curve is their length. So how tall they are, right? There's one for boys and there was one for girls, and there's one for adjusting for prematurity as well, right? Because if they're born premature, they are not going to be on this for a very long time. I think it took Lucas almost 8 months before he hit the regular trim, right? But what we're looking at, so right in the middle of it is that 50th percentile, okay? From the 25th to 75th percentile, that's a pretty good window of where we want them to be, right? So what does it mean when we're talking about the percentile? Do you know?
Like when you compare them to other kids their age or whatever, and then out of that many kids, like out of 100 kids, you're getting false.
Yeah.
What's
Yes.
the percentile range you mentioned?
Okay, so we're looking at like the 25th to 75th percentile. So 50% right in the middle, okay? But we're looking at a good okay window of 25 to 75%. When they get to the lower, reaching that 25, and it looks like they're kind of like on a downtrend, they're going lower, we're looking at why aren't they growing like they should be. If they're above that and they're hitting the top part of that percentile, we're looking at they're putting on weight. Why are they putting on weight, right? So when we talk about a kid who's been placed at the 75th percentile, that means that 75% of kids who were placed on the growth chart fall below where that child placed, and 25% fall above that, right? I said 75, 25?
Yeah.
Okay, making sure I have the right numbers in my head, okay? So when we're looking, so maybe last year they were at the 75th percentile. Now they come in and they're at the 90th percentile. Is that a good thing?
Not necessarily.
No, not necessarily. You have to look at your child overall, right? Are they just really tall and like fit for their age? Because this is not really looking at like their body mass index or like how much muscle they have versus like fat, right? It's just looking at their overall weight and their height. And so then you have to look at everything else along with it. Is it because maybe they're an athlete and they've got a lot of muscle, so they are heavier for their size, right? Or are they obese, and we have to look at more of like a healthy lifestyle sort of thing?
Do you want us to memorize this from?
No, no. We're just going over it because we will somewhat use it in simulation. Okay. I'm just gonna talking about it so you kind of have an idea of like what we're looking at, right? And it's really important when a child is placed on there and we're giving that information to the parent and we're like, oh, your child placed at the 100th percentile, right? And some families are like, yay, 100%. No, that is not good. That means that 100% of all children who place on the growth chart at your child's age are below the weight that they're at. So then we're looking at, is it a diet thing, lifestyle thing, or is it a medical condition that's causing them to have all of this excess weight, right? And so we need to take a look at that and look at
Specifically for like weight though, right? Like length, it could be
more so for weight, yeah. The length though could,
if they're like astronomically, maybe they have some sort of like
they could have, yeah.
pituitary gland issue or
But then look at the parents too. Are they tall?
My baby is like
Right?
that, and she just turned 2 and she looked like she's 5. Like she's like a
You're tall.
But you're tall. So again, you have to look at the genetics. Look at the parents, right? If the parents are really short and you've got a short statured kid, that's kind of expected, right? But if you have tall parents and you have a taller kid, that's kind of expected. But if you have really tall parents and a really short statured kid, that could be a problem because then we're looking at maybe pituitary issues and do they not have, are they not producing growth hormone? Is there a tumor that's like an issue that's causing that? Or do they have some other genetic condition that's keeping them at a shorter stature?
Or our parents over.
Right.
But
Or it could be that too, absolutely. If they're not getting the proper nutrition, not only are they not growing, they're not growing taller, right? But they're also not putting on weight either.
Because if you
Or
like
vice
look at this
versa.
Or vice versa. Or if they're overfeeding.
You grow up wearing white,
Yeah.
you're from white, you were Mexican.
Yes. So what I have on here, so you don't need to memorize it, but essentially what we're doing, we're looking at across the top and across the bottom is their birth in months. So this one only goes up to 36 months, and then they have another one that's beyond that. So you're going to look at where they are as far as how old they are, and then what their length was and what their weight was, and you're plotting it on the chart, right? So again, as long as it falls somewhere between the 25th and 75th percentile, it's a pretty good window of okay. But if they're closer to those margins, then we're looking at really more of an in-depth, like, do we need to start focusing on like healthy lifestyle, healthy diet, healthy activity? Or are they not being fed enough? They're underfed? Are there some other issues? Like, is there a socioeconomic component? Can they not afford food? Those sorts of things.
Is there any part, like, as far as, should they match? Like,
The height and the weight?
should they be 50th percentile this and 50th percentile that?
Not necessarily, no. That's all all dependent on the child. As long as they're falling within those ranges, they're good. Yeah, but there's nothing that says like if they're at the 50th percentile
Just
for
like my
weight,
daughter,
it should
she's
be.
like always 50th percentile for weight, but she's like 80th percentile for height.
Yeah,
She's just, like,
you're
wrong.
gonna find that all the time. Yeah, but the biggest thing with these, once you plot them, you're looking at, is there a potential to identify a growth issue, right? Can we identify early that there's something and do we need to intervene? Okay?
But it is a little like, cause they always say, well, like how much is she eating? And I was like, she eating like regular kids eat. Like she just big, and so then it makes you feel bad, like you doing everything you're supposed to do, and she just big. Like you know, not like she's not fat, but she tall, and she just she
Yeah.
she got a lot of
And that's just who she is. Yeah. But then there's there's infants who have, like, their roles have roles,
Yeah.
right? You're overfeeding your infant and this is not going to be healthy,
Yeah.
right? Because then we're looking at, like, that's setting them up for early childhood obesity and a potential, like, early onset for diabetes, right? And so it's like, yeah, you have to back off a little bit. Like, yeah, your kid's probably going to scream that they're hungry, but you need to get them to a healthier weight, right? Because that's really most important, right? We don't want to just feed them to feed them. And a lot of time that happens because, like, parents don't understand that kids cry for different reasons, and so every time they cry, they give them something to eat. They stuff a bottle in them, right? And that's not not necessarily what they need.
With my daughter, because there's times, like I said, my daughter was super picky. He's like offering the healthy stuff, but a lot of times parents will panic and be like, oh no, they're not eating, so they'll just give them whatever they want to eat.
Yeah.
He's like, you can eat a donut even if you're not hungry because it's a donut and it tastes good. He's like, don't, just keep offering the healthy things. Don't freak out and give in.
Yes.
And offer just unhealthy
Because
stuff.
kids will cave, and when they're hungry, they'll eat, right? They will not starve themselves. They will eat. Now, if they have like autism or something like that, that's where it gets a little tricky, because they do have like texture issues and stuff like that, and it is a part of who they are. So then we have to adjust to that. But someone who doesn't have those issues, they'll eat, right? Just keep offering those healthy things, and they'll eat for sure. Okay. So going into the physical exam. So what is our role? We've already talked about building rapport and trust and how we do that, right? Using good tone, getting on their level, right? Building that rapport, maybe talking to parents first, okay? Approaching them developmentally, right? Again, how old is your kid, right? And how are you going to address your approach, right? Do you have to talk to parents first, or can you go in and you can just talk to the child, right? And not freak them out, right? All of that incorporates effective communication, right? Be clear in what you're doing, right? Talk to them, establish that rapport, allow for feedback, right? So if they have questions, so if they have questions for you, answer them, right? You can stop what you're doing and you can talk to them. Like, you don't be so task focused that you have to get something done right now because it's 8 o'clock, it's assessment time, right? Things change. You have to be a little bit more fluid, right? It's okay if you don't get your assessment done until 9:30. If there's something else that's more important that you have to focus on, right? It's okay. Okay. And then going through a systematic examination and data interpretation, right? If you do your assessment the same way every time, are you going to forget things? No, right? So get in the habit of doing a very good systematic assessment. You start at the head, you end at the toes, you should be finished, right? You shouldn't have to go back for anything. Again, adjusting for the developmental approach. If you have to do your vitals first, if you have to auscultate first, right? That's another thing. Auscultate everything all at the same time, right? Your window on most kids is like this big, right? Can you listen to heart, lungs, and bowel sounds all at the same time? Yeah. Can you do that on an adult patient? Yeah. Why not? Right? Listen to everything you have to listen to. Why put your stethoscope in and out, in and out, in and out, right? Because that is increasing your risk for what?
Them getting anxious and pulling away and you having to stop.
It could.
Like missing stuff.
Infection control. The more times you're touching your patient and touching your stethoscope and putting it in, on and off, you're risking touching your own face, and just kind of spreading whatever germs and stuff they have, right? So just put it in one time and listen to everything. right? Whether it's a young kid or an old kid or an adult, right? Listen to everything and then put your stethoscope off to the side and continue on, right? Again, get in the habit of doing that systematic evaluation, right? Because you're less likely to miss something.
I saw that we have like the percuss. Do you hear percuss?
No. It's not something the typical bedside nurse does. Yeah. Okay. And then from the data that you're collecting, you're going to interpret it, right? So what does it mean when I hear a heart sound that doesn't sound normal, right? What am I gonna do about that? What does it mean when I hear lung sounds that don't sound normal? What am I gonna do about that, right? So you're gonna interpret that and you're gonna take that back to your physician and be like, hey, when I did my head to toe assessment, I heard a murmur in the heart, right? Depending on their age and why they're there, the physician might tell you, just keep an eye on it, right? Or they might tell you, go check their temperature. Why? Really doesn't have anything to do with a heart infection, but kids are really good about throwing murmurs with a fever. It's very strange, and it has happened a number of times. So I've heard it, I've checked their temperature, they have a fever, we've treated it, and the murmur went away. So if they're there for some infectious process, they're gonna tell you check the temperature. Yeah. Yep. The heart's angry, so it throws a murmur, right? However, if they're not there for any sort of infectious process, maybe they're just there for, a fracture or something like that, and you hear it, and it's beyond the age that they should have a murmur, right? So maybe they're within the first 2 months of life and you hear one. Is that a normal time to hear a murmur? It can be. It can take months for like an ASD or a VSD to close. So you might hear one, right? Because those are normal fetal openings in the heart, right? To allow for circulation that just didn't close when they should have, right? So you might hear that. So if you hear it beyond where you should, then it's an issue and they might go in for an echo. And we'll get more into that in cardiac, okay? We could have already talked about this, so your developmental considerations, tailoring your approach. So again, how old is your kid? How are you gonna approach them, right? And you're gonna adjust that based on their age, right? And their developmental level, right? So again, if we've got an adolescent who's at the developmental level of a 5-year-old, you're going to adjust your approach to that of a 5-year-old and not of an adolescent, right? Because that's where they're at, and you're meeting them at their level, right? Cool? So your physical exam. When does your physical exam start? As soon as you walk in, right? Because what data are you going to get as soon as you walk in?
Airway, circulation.
Their airway, their circulation. What do they look like? It's their general appearance. What position are they in? Do they look like they're stressed out? Do they look nice and calm and relaxed? Right? You're going to get all of that on their general appearance, their activity level, their mood, right? All of that starts the second you walk in the door, right? You're starting to gather that data, okay? Then we're going to look at their measurements. They're getting their height, their weight, their head circumference, all of those things, okay? And then we're going to go through and do our exam, okay? And again, adjusting for things that we want to do first in case the child gets upset, right? So auscultating is a good place to start, because once they get upset, is their head circumference going to change? Is their rash going to change? No. Is their fracture going to change? No, right? But is their heart sound going to change? Is their respiratory rate going to change? Are you even going to hear the respiratory rate if they're crying? Probably not, right? So getting the things that will change if they start getting upset. You want to get those things first, okay? Okay, what order do we do our assessment? That, right? Right there. Look, listen, feel, and then percuss. That last one, do you ever percuss?
I just had this conversation with the block ones on Saturday, and I'm all, no. But then after we read on, I was like I've never palpated liver successfully. But things like if they have a chest tube and they have crepitus, you do feel for that.
But that's more palpating versus percussing.
Yeah, I guess.
Because the percussing,
So I'm gonna say no, you're
so
right.
the percussing is where you're going over like their organs, and you're
I
like
believe
kind of
percussing.
listening for like air, or like the density essentially. I've never done that.
No.
I don't ever see any other nurse do that.
Is to break up stuff. Like
Yes.
for diagnostic.
Yeah, we do like chest percussion, but that's like
Yeah.
in an intervention. It's not an assessment thing that we do.
That's all I can think of.
So that is more of a physician or like nurse practitioner level stuff. We really focus on the inspection, auscultation, and palpation, right? So we look, listen, and feel, right? We do it in that order because once we start pushing on things, could that change what things sound like?
Yeah.
Absolutely, especially the vowels, right? So we want to look, listen, and feel in that order, okay? Okay. So blood pressure cuff placement, we can do it on the brachial artery, so normal upper arm placement, right? We can also do it on the radial artery, closer to the wrist. That's rare. I don't hardly ever do it there. The other place that we really do it in kids is their dorsal pedal, so on their ankle, right? So our younger kiddos, like less than 1, we'll do on their ankle. Our older kids will do it on their upper arm. Okay. When it comes to your heart rate, respiratory rates, they are much higher when they're an infant, and they slow down as they progress, right? And once they hit adolescence, they're more towards normal adult readings. Okay. These are. This is not the chart from your book. There is a chart in your book. It is fairly close to this. If I were to give you a vital sign reading, it will be so far out of the normal range that you're going to know it's abnormal for that age, right? So when you're looking at like vital signs and normal ranges, depends on your facility, the resource that they use. Might be off by a couple of points in either direction. Much like with lab results, like some healthcare facility might say that normal potassium is 3.5 to 5, where another one might say it's 3.7 to 4.2 or something like that, right? Or 5.2, something like that, right? But it's fairly close. So if I were to say, they've got a potassium of 2, is that abnormal? Yeah. Okay. So it's going to be so far outside of that it doesn't matter what resource you're using, you're going to know that it's abnormal. So whether you use this one or the one in your book, you'll know that it's abnormal. Okay. Okay. So starting with the head, what are we looking at? Okay. Size, shape, symmetry.
And the babies, the fontanelles.
The fontanelles. What else with the babies? Okay, looking for any like hematomas, capit, anything like that.
Any of like what are those? The strawberry thing?
Like the hemangiomas. Okay.
Rashes,
Huh?
like rashes or
Rashes.
discoloration.
Discoloration,
Bruising.
birthmarks, bruising, hair distribution. Why is hair distribution important?
Because we know that.
Yes, because if
Maybe
they
don't get tummy time.
maybe they don't get tummy time, they're not held a lot, right? So if the back of their head is pretty flat and they don't have any hair, they are not being picked up and they are being left on their back a lot, and they are not getting tummy time, right? So their head can tell us a lot. Strabismus, okay, what is strabismus? It's a fancy way of saying they're cross-eyed, right? It is normal for an infant to have that intermittently up until 6 months of age. Beyond that, it is abnormal, and then we have to look at some interventions, Okay, and we'll get into that week 4. Okay, pupil light reflex. What can that tell us? Yeah, we're looking at their cranial nerves. Do they have the appropriate response to light being shined in their eyes, or is there a neurologic issue that's preventing them from having that, like a concussion, right? Maybe they've got one super dilated eye and one that's super constricted, right? Are they moving with light or are they fixed? What can we learn about looking in their mouth and their throat? Hydration status, infection, specifically strep. It's going to look what? White patchy, red, right? So if it's bacterial, they'll have the white patches. If it's viral, it'll just be red and inflamed. They won't have the white patches. What else can looking in the mouth and the throat tell us? Their dentition, right? So do their teeth look good, or do they have like dental caries? Are they being put to bed with a bottle every night and their teeth are just soaked in sugar, right? And their teeth are rotting away. Okay, it can tell us a lot. What about their ear canal? Okay, looking at their ear for infection. Is there something in there? Right? Kids are pretty good about hiding all sorts of things in all sorts of orifices, right? For whatever reason. So we can look in there to see if there's infection, inflammation, are there foreign objects in there, right? For our kiddos, when we're looking in their ear, we have to pull down and back if they are less than 3, and we're going to pull up and back if they are over 3. Okay?
That's just like due to the anatomy of it?
Yes, because as they grow, it shifts, and like the way that you're gonna look directly into it is gonna depend on whether they're over 3 or under 3. Okay. What about their skin assessment? So starting with the skin color and texture, what can that tell us? Is it appropriate for their ethnicity? Right? What else? What about their skin texture? Okay, yeah, do they have eczema? Do they have rashes? Do they like have psoriasis? Their temperature, right? Is it cold? Is it warm? Are they diaphoretic? Right? Because what can that tell us? Why would they be diaphoretic? Maybe they got fever, right? Okay. Or they're just hot. Okay. Looking at rashes and lesions. So when we're looking at those, what do we want to know about them?
Their shape or their spreading, their location.
Where did all of that. Their shape, their location, is it spreading? Where did it start? Where did it spread to? Because is it itchy? Does it burn? What's it feel like? Is it oozing? Right? Some rashes start at the core and spread outwards. Some things start in the extremities and work their way towards the core, right? Is it head to toe distribution? Is it localized? Where is it at, right? Lesions, why do they have a lesion? What is that lesion from, right? Is it a pressure sore? Again, are they not being moved? Especially like, our older kids who are confined to bed and they need that, every 2-hour movement, okay? What about birthmarks and pigmentation? Why is that important? Because sometimes they can look like bruises. Which ones specifically? Mongolian spots. And who are we going to see those in most often?
Like Hispanic or
Those with darker skin tones overall. Yeah, those with darker skin pigmentation is where we're going to see those Mongolian spots the most,
my
right?
daughter had it. She's 3/4 white.
Yeah,
I have my skin,
and it can happen, right? But why is it important that we document those, especially at birth? Because they can look like bruises, right?
Like bruises.
So when they come in for their next well child visit, they're not all, calling CPS because their baby's been beaten, right? No, it's just a skin pigmentation thing, right? What about hair and scalp? Looking for lice, yes, right? Again, distribution, the texture, like is it dry and is it brittle? Because hair texture can change based on like nutrition, their health status, right? So we're looking at, is this a healthy individual? Is this not a healthy individual, right? What about their nails?
That kid has 6 fingers.
They have extra digits.
Yep.
Check if they have 6 fingers.
Exactly. Do they have more digits than they're supposed to? Right?
My kid has 10 fingers. Well, 4 of them are on one hand and 6 are on the other.
They just have the extra digit. It happens. They just didn't amputate it.
But your kid has 10 fingers. Well, I mean, 6 of them on one.
Shall we miss that one?
Oh no, there's more.
Diego, we amputated a finger on the wrong hand.
See, it's a fun talk.
This is what AI does.
Isn't there some like deficiencies that can show up in the nail?
They can. Clubbing also shows up in the nails, right? Clubbing is a result of what? Hypoxia, chronic hypoxia, right? So we're gonna see that in our kiddos who have like cystic fibrosis or something like that, right? Where they've got chronic hypoxia. Skin turgor, hydration, right? So we're looking at that, tells us our hydration status, okay? Looking at our cardiac and respiratory assessment, starting with our cardiac, we're gonna listen to it. What are we listening for? Murmurs. Really looking for S1, S2, right? We wanna know, or all those other things. Are there clicks? Are there gallops? Are there murmurs, right? Looking at their pulses, checking their strength. When we check their pulses, are we gonna check on each side at the same time? Yes. Why?
Make sure they're
That they're equal,
equal.
right? Are we going to listen and feel at the same time?
Yes.
Yes. Why?
You want to make sure that the heart matches what you're feeling.
Exactly. You want to make sure that every beat of the heart is hitting the periphery, right? So you're going to listen and you're going to feel at the same time. And so every time the heart beats, you should feel it, right? Okay. Looking for signs of cyanosis, pallor, edema, right? Edema can be a sign of what? Heart failure, okay? It could be a renal thing, okay? When we're looking at the respiratory assessment, what are we looking at? Breathing pattern, lung function. Any signs of labored breathing, like what? Accessory muscle use, where are we gonna see that?
Your belly breathing.
Okay, belly breathing, suprasternal, substernal, intercostal, right? So when they breathe in, essentially, we're gonna see their rib cage, right? Head bobbing, nasal flaring, all of those things are not normal, right? Those are not normal findings and indicate respiratory distress, okay? In addition to looking for those things, what are we listening for? Okay? Normal lung sounds is what we want to hear, right? But abnormal things like crackles, wheezing, stridor, right? Differentiating between upper breath sounds and lower breath sounds. So we'll talk more about that in respiratory next week. But stridor is in upper respiratory, crackles, wheezing is lower respiratory. Okay. Grunting, okay. Stridor could go along with an infectious process, or it could also go along with an obstruction, right? Maybe they swallowed something like a quarter.
What's the difference between wheezing and stridor again?
So wheezing is a lower airway sound. So you're going to see that most often with like an asthma exacerbation, where their airways are being constricted in their lower lung fields, where stridor is an upper airway. So you're going to hear it up here. And stridor is like with croup. It is different. Wheezing is more musical, whereas stridor is like a very high pitched, like kind of screech. Yeah, we'll go over those sounds next week. Coughing. Is it wet? Is it dry? Are they bringing anything up? If they're bringing anything up, what's it look like? Right? Okay. The GI, GU, right? Starting with GI. Don't tickle them. Right? This is going to affect your assessment because if you tickle them, are they going to guard? Yes. And guarding is going to feel very firm, right? We don't want to chart that they're firm because we tickle them, right? So do your best not to tickle them, but we'll also still like getting your data, okay? And make sure that you're kind of using a wave pattern, right? So we don't want to just like push here, push here, push here. We want to kind of wave it across, right? And so where your fingers end, you should like, kind of like an inchworm, right? So then you're hitting every aspect of the abdomen, right? And so that you're not missing something. Because if you jump from here to here, could you miss something in between? Yeah, right? So you want to make sure that you're just kind of using that kind of inchworm wave-like motion across their abdomen, okay? With their GI or GU, what do we want to look for?
Hygiene.
Okay, their hygiene. Are they cleaning well?
Abnormalities.
Any abnormalities like?
Redness.
Redness. What?
Discharge, irritation.
Discharge, irritation. Lesions.
I work at a daycare and
Okay.
there's a little boy who's.
Is he split?
He doesn't have a penis.
Oh.
It's like inside of him.
Oh, interesting.
It's very strange.
Okay.
There's like an opening where it's supposed to be. I looked it up and it's like, if it doesn't come out by 3, they usually do surgery.
Interesting. Have you ever seen that?
No.
I've never seen that.
It's
But there are a number of things. So things like that, hypospadias, epispadias, and so we'll go over those more when we talk about like in our GI/GU lecture. But abnormal openings on the penis, more common in men than in females, but it can happen.
Like where it comes up the side, right? Like the urethral opening.
Yeah, it could come out the side, it could come out the top, it could come out the bottom, just wherever it opens. Yeah, and we'll go over that more. But looking for adhesions, palpating for testicles, right? It's really important that as you're palpating the scrotum, that you're blocking the inguinal canal. Why?
That you're what?
What'd you say?
So when you palpate the scrotum, so see they're palpating the scrotum, so they're looking for testes in the scrotum. Why are they blocking the inguinal canal? Because you could accidentally shoot that testicle back up inside that inguinal canal, and that is not okay. Right? We want, if the testicle has already come down, we want it to stay down. Right? We don't want to shoot it back up inside. Okay? Cool. All right, so their musculoskeletal and neurologic system, what are you looking for in their musculoskeletal system? Okay, range of motion. So the reflexes are going to be in their neurologic system, right? That's what you're testing with the reflexes. But with your musculoskeletal system, are they moving everything the way that it should, right? So with our newborns, infants, are they moving symmetrically? Are they moving, appropriately, or are they not moving one? Say if they're not moving their arm, what could they possibly have?
Broken arm.
Could have a broken arm, broken clavicle, right? Maybe some birth trauma where they had some nerve damage there, so it'd be not only a musculoskeletal but a neurologic thing, right? Where they've got some nerve damage and they're not able to move their arm. Okay. For our older kids, can you do this, right? Can you move around without issue? Okay. Our neurologic system, like you said, looking for reflexes. So we're looking, are they brisk in newborns, decreasing to normal by 5 months? So a lot of their reflexes should go away, like their Babinski, their Moro reflex, okay? And then You know, we can use the reflex hammer. We don't ever do that inpatient, right? Have you ever done? No. We don't go that in depth inpatient. These more in-depth assessment things where you're using like the tendons and stuff like that, they could use them during their well child visit, or they may use them if there's just an abnormal finding. Okay, so if everything looks good and kosher and like they're growing and developing like they should, they're not going to do a huge in-depth assessment to make sure that like their patellar tendon works, right? If they're moving and they're walking around, does their reflex work?
Yep.
Probably. Okay. All right. Their endocrine and hematologic assessments. So some key items there for the endocrine. So we're looking at monitoring their growth patterns, right? So that's where those growth charts come in. So when we're charting those, is there a pattern that shows that maybe they're not growing quite like they should? Then do we need to work them up for like an endocrine issue, right? Do they have a pituitary thing? Do they have something else going on that we need to take a look at? Okay. This is also where we'll evaluate the pubertal development using the Tanner staging of age-appropriate sexual maturation. Okay, have you guys heard of Tanner at all? So in the case study that we'll do at the end of class, it does mention it in there, so you can use your resources to look it up. But essentially, it goes from 0 to 5. So 0 being they look like what they should look like at birth. So they're smooth, there's no hair, there's no like breast development, anything like that. And then as they mature and grow through puberty, those stages will they'll go into those different stages based on where they're at when they start having like breast bud development or start sprouting pubic hair, armpit hair. For boys, their testes get larger, their penis gets larger, like all those sorts of things. That's where the Tanner staging comes in. So when you're looking at an endocrine issue for like an adolescent patient, should they have signs of sexual development? Yes. Yeah. In an adolescent. Yeah. In an adolescent, they should, right? They should start to develop like their breasts, their hair, stuff like that. But if they come in and they are completely smooth and completely flat, is that a problem? Could be, right? Absolutely. So then we're going to look at, do they have an endocrine issue that we need to take a look at? Okay. Their hematologic system. So we're looking at, do they have a history of bruising easily? Do they have prolonged bleeding? So if they get a scratch, does it take a long time for them to like clot and stop bleeding? So remember back when we started with our comprehensive history, right? These are the things that we want to know. Do they have a history of these things? Okay, because that's going to lead us into what system we really need to focus on, right? So when we have someone who's coming in with easy bruising and maybe some prolonged bleeding, what could they potentially have? Liver problem? Okay. Hemophilia, right? They could have a hemophilia sort of thing. They could maybe even have like a leukemia, right? If they've got like the abnormal bruising and stuff like that, they don't know how they did it, it just happens, okay? Cool.
Also, a lot of the GI kids, like Crohn's or ulcerative colitis, they'll have absorption issues, yeah, and so they might need to get iron, or they might need transfusions.
Yes, absolutely, yes. So our celiac kiddos as well. So if they're not following a good gluten-free, they'll have an absorption issue as well. So then, yes, that kind of goes into like the proper diet, stuff like that. Looking at those sorts of things. Oh, hi, Tanner. So stages 1 through 5. So for girls, we're looking at breast development, pubic hair distribution. For boys, same thing, but looking at scrotum size, penis length. Okay. So hair for both of them, and then gender specific things. Okay.
At what age?
So once they start hitting puberty, So for girls, like around 9, 10-ish, right? And for boys, 10 to 11-ish is when you should start seeing them move from like 0 to like 1. Okay? And then as they move through puberty, you're gonna see those other things. Because then you're gonna look at, like, for boys, their voice gets deeper, like those sorts of things. Okay. As far as testing on the Tanner stages, we will not, but you'll need it for your case study too. Okay. Okay. Go ahead and take a quick break, and then we'll get into health supervision.